Libya is located in the Mediterranean Sea and therefore much nearer to Europe as initially thought. It covers an area of approximately 1.8 million square kilometers, of which 85% are Saharan desert. The population is 3.4 inhabitants per square kilometers. In 1951, Libya separated from Italy. In 1969, Libya proclaimed to be a kingdom. However, Gaddafi couped and acted as a dictator until 2011. In 2011, revolution and civil war took place and Gaddafi was killed. Afterwards, the Libyans started in a new era. Regarding its social system, Libya has a Human Development Index. No. Regarding its social system, Libya has a Human Development Index of 0.75, making the country to the best developed country in the African continent. The social system is deeply founded on the Sharia and the Quran. There is a constant financial support for those who are in need. Most of the wealth is generated out of their oil sales. 2.7% of annum of the national budget is spent for education. There is a compulsory and free school education for the youth, but for some reasons Gaddafi dismissed schools and teachers, or he refused foreign language studies for all. 70% of the population are reported to be illiterates. In 2005, 30% of the population was reported to be under 15 years of age, which sounds like being in paradise for us pediatric surgeons. In addition, healthcare for Libyans is free of charge, at least in the governmental hospitals. On the other hand, Western experts reported a lot about healthcare problems and substandard care. Besides the national healthcare budget, the Libyan Council and the Western world released an extra budget for civil war victims to be treated abroad. One of such a medevac mission caused my first contact with Libya. Please believe me, purely by accident, I get on this mission and on board of this air ambulance. Shortly thereafter, I met the German Libyan Healthcare Corporation. Next one. And after substantial political changes, an agreement with the owner of the Libyan German hospital in Benghazi could be finalized. From now on, my personal mission, bringing pediatric surgery to Libya, has started. Next. First, I get familiar with the hospital environment in the governmental as well as private sector. I had to learn about patients' attitudes, beliefs, and access to general health care, and especially pediatric surgery. I had to learn that there is only very sparse body knowledge within the families, no rational approach to any disease, and a big mistrust in the doctor's profession. The new arrival of the Dr. Alemann is usually announced by banners in the hospitals and in the city or by broadcast. After my arrival, newborn surgery could be performed in the private sector for the first time. Regular ward rounds and staff tutorials improved our skills and performance rapidly. Thus, we were able to welcome our newborns much better in our newly renovated baby unit. Step by step, the entire spectrum of pediatric surgery and its potential therapeutic options could be introduced. Step by step, the families could get familiarized with the German standards of pediatric surgical care. Slowly, they started to realize that there are pros and cons as well. But one point needs special attention. If the family can present a certificate of a foreign doctor, they can apply by the government for payment of medical treatment abroad, plus some extra money. Some other family members might depending on. In fact, no real diagnosis is necessary for this. Therefore, family expectations are pushed easily off limits due to the lack of medical background knowledge and the general mistrust in doctors. Most of the time, 100% recovery is promised or they are charged for surgeries that never took place. To provide trustworthy and convincing normative information for these families here was and is a challenge. Next. Among all staff, we developed team resource management and started to learn together and from each other. Workshops and skill stations were offered on emerging problems out of our daily clinical practice. Individual support was provided on request. The chance to earn credits and certificates for their professional career was highly motivating and broke down pre-existing cultural barriers. In due course, a closer relationship with the Benghazi Medical Center and the Benghazi Children's Hospital started. We treated severe cases together, and I designed a lecture series in pediatric surgery for the master candidates. Finally, this group could sit and pass their exams for the first time after many years of civil war. On this slide, our most important general achievements are summarized at a glance. In the background, you can see some other of the changes in and outside the hospital and Benghazi for comparison. These graphs illustrate the number of pediatric surgical patients seen in each time period. Numbers of surgery indicated are present in blue and reach around 30% of all cases. Numbers of surgeries performed are always limited due to finance, decision-making, and, of course, inshallah. This graph illustrates the surgical procedures classified according to our pediatric surgery subspecialty. In accordance with the Libyan tradition, most of them belong to abdominal and visceral, but the need for pediatric urology cases expertise is obviously seen. Pediatric orthopedic cases are an ongoing problem because of the resistance of the adult orthopedic surgeons and their traditional views. This graph illustrates the number of ultrasound scans and educational activities performed during each time period. Ultrasound scans get well and rapidly accepted, like the educational activities for all staff, since nothing like this has been provided any time before. In conclusion, culture-sensitive implementation of German pediatric surgical expertise allowed for the first positive changes in specialized pediatric surgical services in Benghazi. However, for a full and sustainable implementation, there is still a long way to go. We put all our hopes in the summer elections 2014 for a prosperous future, but we had to face the big crash instead. Advised to leave Libya immediately due to the restart of the gunfire. Thank you very much for your attention and the kind invitation to this symposium.
Thank you, Andreas. This one. Yeah. Thanks very much, Andreas, for that presentation. Now, just a short time for questions. Anybody to question? Yeah, sure.
Yeah, you showed us the results, how you improved the surgical service for pediatrics. But I was wondering, how was it like to work in a very harsh political environment, like in Libya, where there's still a civil war going on?
It was not easy, of course, and you have to try to adapt. And there is a big difference between Benghazi and other parts of Libya all the time. It was the safest area, you can say, and the most, let's say, in inverted commas, civilized area at that time. And that make it possible to do there. Maybe in Tripoli, it would not have worked like this. So this is also how the environment and also the emotions was in this area was completely different. And let's say more progressive and liberal to German people coming in. They have a higher respect in principle.
Considering that pediatric surgery requires a lot of skilled anesthesia services, how was the anesthesia services or did you take in your team somebody for anesthesia?
Yeah, at the beginning, we have been lucky because the chief anesthetist, the local chief anesthetist of Libya, has been also for several times in Germany to be trained. So he could also do the small kids. And later on, a pediatric anesthetist from Europe joined our team, and then he was taking over because they could work together and improve the number of surgeries that could be done, of course, as well.